What I'd like to introduce you is something that I call the Pompe Gestalt. So what is Gestalt? It's a German word, and I'm German, of course, but it's a philosophic term. Gestalt means more than phenotype. So the complexity of a disease is different to just what we call phenotype. So Gestalt is something you can easily catch normally. So a bird watcher, with the shade of a bird, he already knows this is the whatever type, eagle or whatever you consider this. And even if you're a whale watcher, by the waft of the whale, you can name them and give them really an identity. And that's something what you need to do if you do a Gestalt approach to the disease. And what we are doing here is in a way similar. If you look at the multisystemic events, what happened in a person living with Pompe disease, it's quite a bit, and we mostly care about neuromuscular, and we leave out a lot of the other things, but you will learn today, and especially later on in the talk of Priya, that there are a lot of systems are affected, and we don't take care about them, but there's a need to manage this in future better. And of course, you know about the general burden of the disease. This is really still high. So we have proximal and axial weakness in mostly all of them. And still, if the advanced stages of the disease, we have a lot of people on the wheelchair and they need supportive respiratory devices. And even then, without all this, there's also the most likely difficulty for ambulating, and even fine and gross motor function skills are going down in a way. And still the topic, no one is really talking about this, but the mortality in our even now long-term treated cohort is still high. So this is not solved. It's not the normal way in living this. And we did a study, this is a long time ago already, so in 2017, where we looked at the substantial humanistic burden of the disease. And here you can see that a lot of things are most important. So it's motor disability, of course, it's the respiratory part, cardiopulmonary function, but then all the more soft things coming in. So it's fatigue, it's sleep disturbance, it's pain and anxiety and all these type of things. And so therefore there's a strong relation of the burden, and among the humanistic burden and parameters of the clinical progression of the disease. And also this is something we need to take care. To confront you a bit more on this, so what is really the patient's perception of this? So really turning around, not having always the doctor's hat on, so really looking what is the perception of the patient. And here is a super busy slide, so we can't go in details, but this gives you really some direct and general impacts of the disease for the patients living with the disease. And you have parts of mobility, psychological parts, but also other things, problems at work, studying, financial difficulties coming up here. So a lot of these things we don't talk normally about, and things like just having a meal outside and go for dinner is not always that easy for the patients. And so therefore, compared to the general population, we have a 3 times lower situation in the quality of life. And also with some of the parameters, we see definitely that there's a difference to the normal population in the untreated, but still this turns into treated population as well. So therefore, there's a lot of things we don't cover. And pain is one of them. So that's an old study we did back in 2013. So it's 12 years old, but that was one of the first summaries. And Priya did another study on this, and it backed up very nicely that in Germany and the Netherlands, we have up to 50% of the patients do perceive any type of pain in different parts of the body. And this is one of the top drivers to decline their quality of life. So therefore, this is something we should look at this. So therefore, this talk will really this time focus on the peripheral and autonomic nervous system, and also in part of the central nervous system, because we learned that there's more to go for. So how can we explore this and the nature of this? And I'd like to remind you that in the Pompe Gestalt, there's really the brain damage that also may impair emotional functions. And we know that there's still an ongoing, even the late onsets are ongoing glycogen accumulation in the central and peripheral nervous system. And of course, we have types of neuronal dysfunction and vascular pathology. So we have this from the old autopsy cases, we know it pretty well. And this is underestimated. So we care about metabolism in muscle and try to fix that, and we completely neglect that there's also a brain topic in the disease, not on the very high level and patient by patient differently. That's our trouble, our issue in it, but it's still there. And this all together impacts, of course, the cognitive and emotional function in the LOPDs. And there might be, so this is given in small studies so far, we need to do more work on this. The executive function impairments is there. We have the topic of anxiety and depression in the patients, high levels of pain and fatigue, and also moderately to high impact of impairment in the cognition in some of the patients. And if we look here for the psychological and emotional support of our patients, so what are we doing here? Are we going just prescribing the enzyme and leave them perhaps with a prescription of physiotherapy? And if you look here, this is glimpse into the patient side, you see we are doing not well. So up to 2/3 or even up to 80% say, well, I don't have really the best feedback, perhaps an adequate response to all my questions I have. So there's room to improve for us to do more here for our patients. And if we look at the peripheral nervous system, also there is some glycogen accumulation, and that contributes in part to the pain topic. We did a study for small fiber neuropathy, and it was clear-cut there's also lysosomal storage and glycogen buildup in those. And we have this situation in some of the patients, not in all, but we did not really thoroughly do this in all patients, looking for burning feet syndrome, so restless leg syndrome could be something. And we have some neuropathic pain trials in the extremities of the patient. So the other thing, hardly touched because we also ignore this, is autonomic nerve system function. So there's abnormal sweating in the patients, something we hardly consider because then it could be a 50-year-old woman, it could be a 60-year-old man, so there could be a hormonal influence and things like that, or it's just normal by aging. But parts of this is not normal. Parts of this is just a new facet of Pompe disease, and we don't go for it. And gastrointestinal dysfunction, I think Bria will cover this very well later on, so this is very important. Also neglected and also not on uptake, because some of us are metabolic specialists. I'm a neurologist, so why do I care about urine tract? I don't have the education for this, but if we treat a multisystemic disease, so we need to go for this and look for help, even for us. So therefore, this is super important. And we all know, if we look at the registry data, the data we have in hands for all the clinical trials, that of course the musculoskeletal system and the bone involvement is there, and of course pain is related also to this. We have just a case, Tessin presented, we have the bent spine, rigid spine syndrome in a subgroup of patients, and we have scoliosis in quite a lot of our patients, and if you look at all the wheelchair-bound patients, there's nearly each and everyone has a scoliosis. So this is also something we did not cover well, and we need to do more on this. And scoliosis in one of the old studies we did was up to 1/3 of the patients, but if you look at the aged population, you see it nearly in each and everyone. And of course, there's the topic, if your muscle is weak, then osteopenia and osteoporosis is something that's coming up, and also we need to take care for this as well. So we were interested, and this short glimpse here we did for this was also a cross-sectional survey in many patients with LOPD receiving some symptomatic pain treatment. And a lot of them reported that they take non-steroidal anti-inflammatory drugs, or they take paracetamol, or even quite a bit, and that might over here in the US even be more, taking opiates. So therefore there's a lot of different things, and many of them do perceive also physical therapy alone, or the combination of things. So and still in more advanced stages, where they are more moderate to severe, affected by the disease, the pain level goes up. It's not going down, it's going up definitely. And I had a talk to one of our patients over here, you heard yesterday if you were there, and she perceived just by coming over here, flying 12 hours, definitely the main topic for her was fatigue and pain. And that's it. It was not the weakness that was so in front, it was really the fatigue and pain, what was a high topic in here. We did some interesting studies in this, so there was is physiotherapy something we can help? Unfortunately, so far we did only this in a clinical trial for our standardized assessment in more mild affected patients. So we don't know how good is really physiotherapy and all what we can do on this side in the more affected patients. But still there was already the outcome, what we did all with the different methods, and I go to this directly, that in the most of the patients with more exercise, any type of whatever you can do and expose on them, and what they can afford to do. So this is also something you need to learn. So what is your border zone for having not more pain under training situations? And how can you widen this zone for your fitness? This is very important, but this stabilizes also the pain. So it's really an element not to be neglected. Is a good health for reduced pain with having physiotherapy. And one of the unmet needs is really to understand better the symptomatic pain. So what is really the cause? I told you a bit about this, but this is not very well investigated. But here in the 20 patients in this survey we have here from the UK and from the US, they say, well, most of my pain is not really well managed. So there's some help for this, but it was not really done very well, and we need to look into this in more detail, what could be a better pain relief system here. And regarding how patients manage their pain, so some of them said, well, we use lifestyle, any type of things, we change that, and others said 60% we use pharmacological treatments, and physiotherapy is coming up, and even some different types of device, what you could do, and also then water and hydrotherapy was there included. So there's quite a bit of information, but of course no systematic review on the situation, and especially no studies done. So if we want to understand treatment, so we need to understand really the discomfort and also the decisions for this. So understanding that 90% of the patients said they have a good understanding of the disease and the treatment for the disease, but they have not always a good satisfied answer to all their questions they have treatment-wise. And in 50% they had no treatment-related discomfort, and 40 had a mild discomfort, and 10 only a moderate discomfort. And the decisions were mostly made by the patients alone. And this is a key element I'd like to touch here a bit. We need to come much more to the concept of shared decisions. You need to listen really as a doctor to your patient, and then try to find out what is really this thing perfectly fitting to the one sitting in front of me, because it will be completely a different situation if the next one is coming in. So they all have really their individualized situations, and we need to take that up and then give the feedback and give the understanding why they should perhaps treat their pain differently as they did it before, and then they will have a solution for their pain conditions. So this is important. So my key take home here is that we need to look more for pain and emotion. This is really a hot topic for the patient. It's always coming up in the IPA survey we have yearly from the Erasmus and from the MDA group together. So this is important. Our current understanding is still a multisystemic perspective, but not well addressed in all details. And the current clinical management is based, for sure, on the ERT. The pain topic is better improved, but we need to do more systematic studies on the pain treatment in these patients. And of course, this all is based up in the emotional perception and a shared decision concept we need to go for. So therefore, more work to do. It's not solved all with our current 3 prescribable ERTs. We need to come along with new ideas how to manage all this better.